Dr. Markeil is our esteemed medical director, and she needs no introduction. She's been at the center for, I think we just said this morning, 5 years at Downstate. And a little over 5 years, and she's going to discuss something that is really passionate to her. It's encouraging wellness behavior in the post-kidney transplant patients, diet and exercise.
Thank you so much, Dr. Marchand. Okay, so I have nothing to disclose. So today I want to very briefly talk about how can having a transplant center in our community improve overall wellness in the dialysis population? And what is the definition of wellness and the adverse effects that social drivers, which were called social determinants, could have on wellness in our population? And then talk about a couple of strategies for cardiac risk reduction, including diet and exercise programs. So I think you just saw this slide. The closeness to a transplant center, as you could see, especially in a metropolitan community like ours, the closer you are, the more likely you are to get a kidney. And the closer you are to have a transplant center in your community, your dialysis patients whom you've referred will have an improvement in their wellness behavior. Because as you know, patients who are referred for pre-transplant evaluation get a very careful workup. And one thing we've looked at are patients in dialysis units who have not gone for transplant evaluation, and there's not as high a rate of patients who've gone for, say, cardiac evaluations. We evaluate everybody with an echo, and then a stress test or a PET scan or angiography is needed. These patients all are required to get routine cancer screening, which patients otherwise may not be doing, including colonoscopies or Cologuard, mammograms and pap smears per guidelines. So just having a patient referred for transplant will automatically increase that aspect of their wellness care in dialysis patients. In addition, all of our patients see social work, and they're assessed and referred for services if that's discovered that they're needed. And they'll see a dietitian, and they will be screened for frailty if necessary, then referred for dietary counseling. And I'll talk to you a little bit about the possibility of prehabilitation for these patients. So just from being referred for a transplant, patients are encouraged to undergo all of these wellness behaviors. So what is wellness? Wellness can be defined as occupational, physical, emotional, spiritual, intellectual, and social. Those are the 6 dimensions of wellness that were defined in 1976. And those come in conflict with some of the social drivers, which used to be called social determinants of health, which again, I'll remind you, are the neighborhood and built environment, health and healthcare, social and community context, education, and economic stability. So how would social drivers have adverse effects on wellness in our population? Well, occupational includes lack of well-paying jobs that are available, and certainly for dialysis patients, no jobs may be available, or for patients post-transplant, poor working conditions, inadequate availability of good schools and poor support for educational programs for not only the patients but their children, spiritual issues which can include feelings of hopelessness and difficulties in getting to attend worship services because of transportation difficulties, emotional issues including exposure to violence in the community, difficult family situations, a lack of feeling of community, and as I said, poor transportation can affect social issues as well. And then the physical, which is what I'm going to focus on more, which is poor availability of high-quality medical care, easy availability of poor nutritional choices, lack of affordable fresh foods, and difficulty in accessing safe and affordable places to exercise and walk. You can encourage patients to do exercise, but as one patient once said to me, I think it's more dangerous for me to go out and take a walk than it is for me to sit home and just watch TV. So, I mean, they were being somewhat facetious, but unfortunately, given some of the neighborhoods around New York City, that may be true. And a quote that I always come back to is, our zip code may be more important than our genetic code. So in fact, lack of available healthy food is considered a food desert. And Brooklyn is not a true food desert, but many areas are. And in the United States, about 11.5 million people, or 4%, live in low-income areas that are more than 1 mile from a supermarket, which is the definition of a food desert. Unfortunately, many of those patients live in what's called a food swamp. And a food swamp is an area where there's easy availability of fast food and cheap, unhealthy alternatives. The bad news is that, in fact, East New York is one of the biggest food swamps in New York City. And any of you who drive down Pennsylvania Avenue know that there's a very high concentration of fast food restaurants there. In zip code 11207, there are 27 and 14 in 11208, and this is old data. There was a 14% increase over 10 years. And in fact, living in a food swamp may be as deleterious as living in a food desert. So what happens with food insecurity? There's economic instability as well, and Brooklyn and the Bronx have the highest rate of food insecurity of all of New York City. More people in our catchment area skip meals than almost any other area in New York City. And you can see, again, these are old data, but this area should look very familiar to us, and that is the highest area with food insecurity in New York City. What effect does food insecurity have in terms of medically? Well, in a study that was looked at in patients who had diabetes, those who were food insecure had, not surprisingly, increase in hypoglycemic episodes, as well as higher healthcare and ED utilization, a higher hemoglobin A1C, actually a higher BMI, poorer health-related quality of life, and an increased difficulty in following a healthy diet, which included lower fruit and vegetable intake. And if you think about it, someone who is food insecure may have a cyclical availability of money for their food. And in animal models, it looks like cyclical food availability causes the person to, or the animal, to seek out high-fat, high-caloric food. And so, in fact, although it may seem counterintuitive, many people with food insecurity actually have a poor body composition. The second issue is health literacy. And health literacy is defined as the ability to obtain, read, understand, and use healthcare information in order to make appropriate health decisions and follow instructions for treatment. A subcategory of health literacy is nutrition literacy, which is the ability to obtain, process, and understand basic nutrition information. And if you think about it, you can prescribe something for a patient, either a diet or a medication dose. If they have if they can't calculate or they can't read, they're going to have difficulty following instructions. And if they have numeric illiteracy, they have a very difficult time calculating what they should be eating. You can tell a patient you should eat 2,000 milligrams of sodium a day, but if they can't figure out how to calculate that, they're not going to be able to do it. Physical factors can affect literacy as well. So visual ability, we just did a study, and our patients, many of them have poor visual acuity, but they won't tell us. And these patients may have diabetes, some of the elderly, they have cataracts that haven't been taken care of, and they're sight impaired. The font of food labels or prescriptions may be very small. Secondly, they may not be able to read, and they may feel uncomfortable in telling you this. Their native language may be other than English, and many of the instructions they're given are in English. They may, as I said, have numeric illiteracy, which is the inability to understand portion size or medication dosage, and an inability to calculate nutrient intake. And one of the studies that we did here in our hemodialysis and transplant patients using something called the newest vital sign, the mean literacy score was only 1.93 out of 6. Only 18% of the patients scored for adequate literacy, and over 80% were considered to be at risk for illiteracy. So I think one has to be very careful when encouraging wellness behavior in patients to know who the patient is in front of you so that you can meet them at their level and explain behaviors in a way that they understand. So I want to go on then to talk, and then this is the same thing. 81% in the study had seen a dietitian for dietary counseling, and 15 in the past year. But in fact, very few of them scored well on the healthy eating index, although 66% believed their diet was healthy. And the interesting thing, though, was that the low literacy patients, although they were older, they weren't different in terms of their healthy eating index or education or income. So I think overall our patients had a fairly poor diet quality, despite the fact that they were getting monthly dietary counseling when they were on dialysis, and they also saw a dietitian after they were transplanted. So how can we approach wellness strategies in our patient populations? You know that cardiovascular risk is increased in both patients with end-stage kidney disease who are on dialysis as well as those who are transplanted. They have traditional risk factors, including hypertension, dyslipidemia, diabetes, and tobacco abuse, but they also have non-traditional risk factors like left ventricular hypertrophy, mineral bone disease, inflammation and oxidative issues, and then the presence of immunosuppression. This all leads to cardiovascular disease, which includes heart failure, pulmonary hypertension, arrhythmia, and coronary artery disease. So the point is to encourage wellness behaviors that can offset this. The routinely recommended, and this is the KDIGO and American Heart Association recommendations, are to treat hypertension to a target, to treat dyslipidemia. In fact, interestingly, they recommend in this paper use of statins in all kidney transplant recipients, keeping the target hemoglobin A1C to 7 to 7.5%. And here they recommend a BMI of less than 35, which is a relatively, I think, is not a particularly strict recommendation. But as you heard, we are trying to widen our access to transplant for patients who are in the more obese category. And so patients who are over 35 kilogram per meter square BMI, we should be recommended to have some sort of a approach for weight loss. And then, of course, to stop smoking. So these cardiovascular risk factors are modifiable by diet and exercise. I think everybody knows this: high blood pressure, hyperlipidemia, glucose control, and then body composition, especially visceral adiposity. And so one of the things that's been recommended recently is the plant-based diet. So how would a plant-based diet help with cardiovascular risk? There is theoretically much less inflammation in a plant-based diet. The meat-based diets are associated with release of pro-inflammatory cytokines. A vegetarian diet may, as I recently said, as I will show you, may decrease risk factors such as hypertension, diabetes, and hyperlipidemia. And if a patient decides to become vegan, which is not necessary, you can see a difference in their bacterial flora in their intestine, which may improve their microbiome. This is just a look at the prevalence of hypertension in patients who follow a plant-based diet. Again, they may follow other healthy lifestyle choices as well. But here you can see that even a semi-vegetarian, so it is not necessary to go completely vegetarian, has a lower risk of hypertension than somebody who is a meat eater. And again, patients who are semi-vegetarian have a lower risk of diabetes. And again, this is not in patients with kidney disease, but this is in all patients, just looking at population studies, trying to account for other healthy behaviors, but many people who follow a vegetarian diet may have other healthy behaviors as well that are playing into this. Be that as it may, there are other reasons why the adoption of a plant-based diet might be recommended for our patient population. So a plant-based diet is a diet rich in vegetables, fruits, legumes, and minimally processed foods with limited or no animal products. It does not have to be a diet that is completely devoid of animal products. And interestingly, plant-based eating is actually associated in population studies with a lower incidence of chronic kidney disease, also a lower incidence of albuminuria. So it looks like plant-based eating may be good for the kidneys, certainly before transplant, and probably after as well, although those studies haven't been done. But how could plant-based eating help? Will it even help in pre-transplant help, in dialysis or patients with CKD? Well, it does cause, as I said, changes in the gut microbiota, which may alter the presence of some of the uremic toxins. It also has and patients are able to eat more protein because, as I'll show you, phosphate is less bioavailable in plant proteins, and so patients can eat more protein, and there's a lower acid load. Animal proteins actually are high in acidic amino acids, such as the sulfur-containing amino acids. And it has been shown that taking bicarbonate may slow progression of kidney disease. So the thought is, because plant-based diets are highly alkaline and result in a decreased acid load, that this may be one of the drivers for the improvement or the decrease in chronic kidney disease that's seen in patients with chronic, who are plant-based eaters, and a decrease in possibly risk for kidney disease. And this is just showing you acidic foods versus alkaline foods. In addition, as I'd mentioned, plant-based phosphate may be less bioavailable. In fact, plant-based phosphate is bound to phytates, and so it's less digestible. And so for a given protein intake, in this study, patients who followed plant-based diets excreted much less phosphorus in their urine. Obviously, these weren't dialysis patients. So one of the issues in patients who are pre-transplant is protein calorie malnutrition. And theoretically, encouraging plant-based eating in dialysis patients may keep them healthier going into transplantation and possibly after transplant as well. And just to remind you, as I said, it is not necessary for patients to become vegan, in which no animal products at all are eaten, or vegetarian, although vegetarian usually includes dairy and eggs. Patients may be pescatarian, and they may be flexitarian. So the Mediterranean diet, which includes small amount of meat, mostly fish, nuts, olive oil, and some wine, as well as the DASH diet, can be recommended, and both of these diets have been shown to actually be efficacious in patients with kidney disease. Now, the old recommendation was not to use the DASH diet for CKD stage 4 or higher, and that was because of worries about hyperkalemia, high potassium. In fact, that doesn't seem to hold water anymore. And again, as I'll mention, the issue with hyperkalemia in a patient who is very careful about their potassium intake is probably not one to prevent them from following a DASH diet. But one has to be careful because there are what are called junk food vegans. Oreos and French fries are plant-based. And in addition to that, vegans may be at risk for, if they're actually vegan, they need to supplement B12. Vegetarians often get enough B12. And vitamin D is probably necessary in everybody who lives in Brooklyn, but it certainly may be necessary in patients who avoid dairy products. The other thing to realize is some of the meat products are extremely high in sodium. They're trying to get away from that, but things like Beyond Meat, Impossible Burger, those things are very, very high in sodium. And in fact, a patient who follows an unhealthy vegetarian diet is also at risk for coronary heart disease. You no longer get the actual benefit. And so it is good to have a dietitian speak to your patients who are interested in adopting a plant-based diet. One of the things patients may tell you is that they can't afford it. In fact, that's not true. There are many, sorry, I skipped ahead. So this was the issue about high potassium, and this recent study suggests that plant-based diets do not result in hyperkalemia as long as the patient is educated about which are the high potassium foods. And in fact, not everybody with late-stage kidney disease needs to restrict potassium, and many of our transplant patients don't need to restrict potassium at all. And so there's no reason for this to be a concern. The other thing is that there are cooking techniques, such as boiling, that can lower the potassium content of food. But again, it's important for the dietitians to speak to patients about this. And then, as I said, some patients will tell you they feel like that vegetarianism or veganism is going to be expensive for them, but in fact, many plant proteins are quite inexpensive, and some patients actually have it as part of their ethnic diet. Things like rice and beans, potatoes, beans and broccoli, things like that. So in fact, fresh fruits and vegetables are covered by many of the food programs now, and so patients should not be, avoid trying to eat more of a plant-based diet because of economic reasons. Then finally, please remind your patients that they don't have to give up eating meat in order to get the benefits. One of the things that I've heard from patients is, I really like my steak. But the point is that to add meat as a garnish rather than a main dish, and that even eating maybe plant-based once or twice a week, meatless Mondays, doing something like that, has been shown to have a benefit. So in the rest of my time, I'm going to talk about frailty. So as some of you heard last night, frailty is defined as a significant decline in functional reserve, and it results in an extreme vulnerability of the individual. And the famous Fried phenotype of frailty includes a slow walking speed, decrease in grip strength, unintentional weight loss, declining physical activity levels, and exhaustion. So extreme frailty is a contraindication to transplantation. So the point is to try to prevent patients from developing that prior to your referral for transplant. And why is that? Well, in fact, in patients with CKD, about 14% of them are frail, and there's an increased risk of dialysis in those patients and death. In patients who are transplanted, about 20% of them are frail at the time of transplant. There's an increase in death on the wait list. They don't get transplanted. There's an increased length of stay. They get rehospitalized. There is a question that they may have an increase in delayed graft function, decreased cognitive function, and death post-kidney transplant. And for patients who remain on dialysis, the patients who are over 65, the estimate is that almost 70% of them may meet a frailty phenotype. Those patients have decreased cognitive function and quality of life, as well as falls, death, and hospitalizations. So the point is, it's very important to be aware of frailty in your patients, and to figure out, is there some sort of a wellness behavior that we can do that will help that. And again, just to show you, this is a slide that Dr. Segev's group actually was responsible for, and it's just showing you here that if you transplant someone who is frail, you have adverse transplant outcomes. So how can you prevent frailty in the dialysis population? Well, the one way is through exercise, which I'm going to talk about. Another way, as I mentioned, is encouraging nutrition, obviously encouraging healthy nutrition and not poor nutrition, comorbidity management, and then senolytics, although there really are no senolytics that I know of that have been used in dialysis patients successfully, but that is a pipe dream. So the point is to try to decrease things like inflammation, muscle atrophy, and malnutrition. And one of the ways that this has been done is to try to create some sort of a pre-transplant exercise program. Dr. Segev last night told us about a program that they've used where they have pedalers for patients to, they pedal while they're on the dialysis machine. And here you can see this is another study that was done with intradialytic cycling. They also had very, very low weights, and they had patients actually do weight training during the dialysis, and then they encouraged them, they gave them pedometers and encouraged them to walk. Then they did another approach where it was really more of a wellness approach with comprehensive lifestyle modification, where in addition to their intradialytic program, they encouraged them to join a gym, and they actually encouraged them to do exercise that was very low intensity when they were not being dialyzed, to walk more, to walk their dogs, to go to the supermarket and maybe park a little further away, to try to use some, sweep up or do some cleaning around the house, things like that. And they really educated patients that that is in and of itself exercise, and to just, be aware that sitting and watching TV all the time is not good for them. So, these actually all had impact on their ability to, on their frailty. So we actually recently did a study where we interviewed 35 of our kidney transplant recipients and looked at frailty as measured by their hand grip dynamometer, averaged over 3 measurements. And then we did a body composition study using an S10 body composition analyzer. And what we found was that actually only, that 43% actually did have some sort of an exercise plan, although the majority of them did not. But they really did want to learn about more about exercise. More than half of them were interested in some sort of an exercise plan. Of the patients who did have an exercise plan, what we looked at was something called whole body phase angle. And what that is a measurement, they call it, of cellular integrity. But in fact, it correlates extremely well with frailty. And the normal values go between 5 and 8. So you could see that the patients who had reported that they do weight training had a significantly higher whole body phase angle that was in more of the normal range than those who did not have weight training. And these are just randomly selected kidney transplant recipients. And they also, not surprisingly, had a significantly greater skeletal muscle mass than those who did not do weight training. And of those patients who did not do weight training, some of them actually did aerobic exercise, but they still had a lower muscle mass and lower whole body phase angle. So I just want to say that, in summary, having a transplant program in your local community definitely increases the chance of being listed and eventually receiving a kidney transplant. It also encourages wellness behaviors in the dialysis and CKD patients who are referred because of the requirement for things like screening for cardiovascular disease, things like colonoscopies, and screening for cancers and general wellness recommendations. However, adverse social drivers, especially in our population, should be recognized because these do serve as deterrents even in the most motivated patient. And ongoing pre-transplant wellness approaches may include things like encouragement of plant-based eating and a graded prehabilitation exercise program, as frailty is associated with poorer transplant outcomes. So I think, in conclusion, I hope I've shown you that having a kidney transplant program in a community, especially one with adverse social drivers, creates many both potential and actual benefits for the patients we serve, both the dialysis and the preemptive CKD patients. It increases access to transplant and fosters wellness behavior both in the pre- and post-transplant period. And this is just some information about plant-based eating. Thank you. So, questions? No questions?